What effective tips when done, doctors treating arthritis can actually get a better quality of life. Number one and most important symptom, you should elicit a proper history of arthritis, that is pain, stiffness, swelling in the joints, which is first thing worse in the mornings, affecting hands and feet, or both knees or both hands and both feet and both shoulders in a female if it is rheumatoid arthritis, in a male if it is ankylosing spondylitis. And in ankylosing spondylitis it is usually unilateral, that is not on both sides of the body, and usually large joints which is in the lower limbs, either one hip or sacroiliac joint or one knee or one ankle or heel, or enthesitis such as tennis elbow, lateral epicondylitis, or even hip bursitis. So what I just suggested is RA is more of a bilaterally symmetrical joint in a female, and ankylosing spondylitis or psoriatic arthritis or IBD related arthritis or seronegative arthritis is more of a male related and asymmetrical oligoarthritis affecting few of these joints. Whereas if it is a lupus, it is more of a female relate, causing more of butterfly rashes, sun exposed rashes, mouth ulcers, hair loss, fever, pregnancy problems, and breathing difficulties such as chest pain causing pleurisy, and blood tests showing more of ANA problems and that kind of thing. If it is vasculitis, you see more of multi-system affecting lungs, fever, very high ESR CRP, joint problems, skin rashes, on biopsy showing small vessel vasculitis in either kidney or skin or nerves. If it is large vessel vasculitis, it is usually imaging, such as imaging of abdominal aorta and MR angiogram or CT angiogram. In case of ultrasound, you can actually see that. Other part is to actually check the appropriate tests, and what tests has to be done to actually diagnose arthritis. So ESR CRP always has to be done at diagnosis and always has to be done at prognosis. ESR CRP indicates a high level of disease and with treatment indicates betterment of the disease. But in a rheumatoid, ESR CRP is usually high. In ankylosing spondylitis or seronegative arthritis, ESR CRP in 60% may be normal. So it doesn't exclude arthritis. ESR CRP high is always in vasculitis, and ESR very high in lupus but CRP normal in lupus. So if CRP is high in lupus, you can think of infections or chest diseases and so on and so forth. Other antibodies, rheumatoid factor and anti-CCP done by a proper NABL accredited lab, the right method called nephelometry, value above 40 will help in diagnosing rheumatoid arthritis provided they have right symptoms. Rheumatoid factor and CCP normal does not exclude rheumatoid arthritis. It just means that they don't have a lifelong, and tablets can be aimed to reduce and stop. Or they might have a seronegative arthritis with a rheumatoid pattern of joint distribution. That is also possible. HLA-B27 done by PCR method is the right test for ankylosing spondylitis. It is elevated only or positive only in 50% of ankylosing spondylitis in Indian patients. So that being normal does not exclude ankylosing spondylitis. You would need something called MR imaging to check for sacroiliitis or enthesitis in the vertebral column. ANA is positive in 99% of SLE patients. Be very careful. If ANA is done by ELISA, it's a wrong method. ANA done by immunofluorescence in a proper NABL accredited lab to check for titer, to check for dilution, starting dilution and ending dilution, and to check for pattern. These three are mandatory. Only a proper lab will know that. That will show whether it is ANA positive, and ANA positive above 160 is always indicative of a connective tissue disease. And lupus does not just mean ANA. Lupus with correct symptoms means ANA, such as all this what I've described before. And sometimes ANA might be negative, but ANA profile might be positive. That also indicates lupus. ANA profile is not a screening test. It is done to actually delineate different types of connective tissue diseases, such as RNP antibody in mixed connective tissue disease, SEL70 in scleroderma, Roux and La in Sjogren's disease, and so on and so forth. Coming to vasculitis, it's usually by symptoms and biopsies such as skin, nerve, and kidney, and imaging tests in large vessel vasculitis such as Takayasu, polyarteritis nodosa such as medium vessel vasculitis, and so on and so forth. Treatment depends on what tests, what disease you're treating. If it is a rheumatoid, usually it's standard conventional DMARDs, which works for even ankylosing spondylitis, lupus, or vasculitis. In mild cases or most of the cases, initially it's usually conventional and synthetic DMARD. If the patient is not improving with this, then we think of biologicals or targeted drugs such as tofacitinib or baricitinib, or biological drugs such as anti-TNF blockers or IL-6 or B-cell blockers. Usually it takes 3 months for improvement with the tablets, so you have to tell patients to be very patient about improvement, and gradually we escalate. Steroids are not needed beyond 1 month. Usually give in intramuscular steroids rather than oral steroid, and gradually escalate the treatment, and if steroid, then gradually de-escalate and stop it by 1 month. Painkillers you do not use for a long time, use it when required only. Reassure patients that arthritis is not a lifelong treatment. The disease is lifelong, but treatment is not, and we can aim to gradually reduce and stop. Give hope to patients. Hope is everything, my friends. Say that they will do very well with correct type of diet and exercises, and if they don't stop treatment suddenly, they will do better and they will achieve their dreams. Do not leave patients in despair that it's a lifelong disease, lifelong treatment has to be taken, and that's what patients feel very bad about it and they change treatment course. So with this in mind, your disease diagnosis pattern very important, right type of tests, right type of imaging, and choosing treatment early is very important to have a good outcome. And we as rheumatologists are always there if your patient is not getting better. Thank you very much.